Hi, I'm Dr. Joseph with During. It's my pleasure to be joined by David Healy. Here again, he's probably the world's leading expert on PSSD. He's written more about it than anyone else I know, and today we're going to be doing a full download of Dr. Healy's perspective on PSSD. You know what it is, and all that. So, David, welcome. Let's start off by talking about what is PSSD.
Joseph, PSSD is one of the most unusual and grim conditions that the psychotropic drugs we use can cause. Way back when I was training first, there was a little awareness that the different drugs could cause different kinds of sexual problems. Like they could make you slower to have an orgasm, to ejaculate and things like that. They could cause penile droop and things like that. There was a whole bunch of things that people knew about but didn't pay too much heed to. But PSSD is an entirely different beast. It's the problem is it causes sexual problems that don't necessarily go away when you stop your pills. Everything
Hmm.
else that we used to talk about were things that, would clear up once you halted your pills. And there's an interesting history behind it, which is there's a man called George Beaumont in the UK who was working for Ciba-Geigy, and he had the responsibility to develop and market clomipramine, which these days is widely thought of as being the most potent antidepressant we have. But back in the late 1960s, when it was actually produced, people said, well, we've got lots of tricyclic antidepressants. Who needs another one? Okay. And George was given the job of trying to work out how to move this forward, how to market it. Now, at this stage, it was a drug that was in Europe, but not the United States, not on the US market at all. And George came up with this idea about getting in touch with researchers around the place. He noted one or two people had said, look, clomipramine a good drug for OCD. So he chased them and got them to do trials on it and published the papers on it. And in the course of doing this, some of the people who he talked to said, well, one of the interesting things about these drugs is that they cause sexual dysfunction in the sense that, you can have a premature ejaculation problem. You can take clomipramine and it'll help cure it. Okay. And George hit upon this idea. This is around 1973. So it's going way back. Uh, he hit on this idea about running an article in one of the lower class mass circulation newspapers in the UK. And it was about this starlet, this film star who worked on TV series and things like that. And he had this article which said that, she was wonderfully happy with clomipramine. And it's a very daring article to run because when you read the article, what it was, she had a boyfriend and she was happy because the boyfriend, when he took 10 milligrams, now the usual clinical dose is 150 milligrams. When he took 10 milligrams, 30 minutes before they made love, he was able to last much longer, which left her happy. So this is
Hmm.
roughly what the article said. And this got word out, well, yes, that these drugs can do interesting things. And George went on to, he worked for the pharmaceutical companies, but he did a good deal of research on what was actually happening when we give the tricyclic antidepressants. What difference do they make when people make love? So he began to open up this field. And one of the other things he did, and this was at a point when his OCD work, okay, had really got places, and clomipramine ultimately ended up on the market in the United States for OCD. And the reason all of the SSRIs have been marketed for OCD is, well, clomipramine is a serotonin reuptake inhibitor, and it's good for OCD. So maybe these other SSRIs are too. At the time, one of the big deals was behavior therapy, and a guy called Isaac Marks was the guru for this. He was the one who said, look, you don't want to be using drugs for OCD, you want to be using behavior therapy. And Marx and George knew each other, were at war slightly. Marx is saying use behavior therapy. and talked. I mean, I can recall being at a meeting where he talked and said, there are awful problems with these drugs. You don't want to use them too quickly. He had a nun that he was treating for OCD, and when she stopped the clomipramine that she had been on, she was having multiple repeated orgasms. And this was terribly distressing for her. Now, this is a condition that we call these days persistent genital arousal disorder. And it's the mirror image of PSSD, which is in one case, your genitals go numb. And actually, within 30 minutes of the first SSRI pill you take, or the first drug that's a potent serotonin reuptake inhibitor, your genitals go numb to some extent. Some people don't recognize it, but you can test them and show that they're actually less sensitive than they were beforehand. And this probably goes hand in hand with the emotional numbing that these drugs cause. So, but anyway, what you get in a proportion of people is just the opposite, genital irritability. And this seems to happen to women more than men. And the oddity about both PSSD and PGAD is, you can have hints that you have it when you're on the drugs because you're more numb or more irritable or whatever than the usual person who goes on these drugs. But it gets even worse when you stop. And this is very like tardive dyskinesia, which is a problem. You can have dyskinesias on the antipsychotic when you're on them. You can actually probably have TD when you're on the drugs, but it's most clear when you stop the drugs and the problem gets even worse and keeps on going for months or years afterwards. And that's very much what happens with PSSD and PGAD also. And one of the other interesting things is SSRIs are not the only drugs that can cause this. We can get it with isotretinoin for acne, that's Accutane. And you can also get a very similar problem with finasteride, which is used by young men for hair loss. So that's roughly the history of where all these things come. One of the interesting things is the companies, before they brought the SSRIs on the market, gave them to healthy volunteers. And one of the things that was very clear with some of the SSRIs was the healthy volunteers, young men, complained bitterly of sexual dysfunction when they were on these drugs for just a week or two. And in some cases, there are hints that the problem went on for a period of time after the healthy volunteer trial, which is only, say, a 2-week trial. After the trial halted, there were people complaining about ongoing problems afterwards. And we now know that the first reports to regulators about enduring sexual dysfunction after an SSRI stopped was roughly around 1987. So before most of them came on the market, there was an awareness among the companies and regulators that problems like this could happen. But when the drugs came in the market, people like me were told, and I'm sure people like you as well, maybe it was a little different when you actually got to hear about them. But when I got to hear about them when they came out first, we were told, well, yeah, you can have a problem when you go on these drugs, but everything's going to be fine once you halt them. And if you want to go away for a romantic weekend, you just halt the pills for the weekend and everything will be just fine. That's what the company said, but that's not what they knew, and that's not what's turned out to be the case.
And so, David, could you tell me a little bit about the diagnostic criteria for this? How do you know whether you have it?
Okay. Well, one of the key things is that you get genitally numb. If you're not genitally numb or irritable, then you don't have one of these problems. And there's all sorts of other problems all of us can have. If you're male, you can have an erectile dysfunction, but this is not PSSD. You may get erectile dysfunction with PSSD, but if you don't have the genital numbing, then you haven't got this problem. And when people with PSSD hear about this, they say, well, it's much more than just genital numbing. And it is. There's emotional numbing, there's a general autonomic dysregulation and things like that, but they're not diagnostic in their own right. They can happen with SSRI withdrawal also. It's the genital numbing that's very as specific to PSSD. And it's the reason why you can't have, as some doctors say to this day, that, well, actually, these people are just depressed. Depression causes us to lose libido and not be able to function properly. No, it doesn't. You have to be melancholic before you lose libido when you're clinically depressed. The usual kinds of states that people get SSRIs for are often the kinds of states that many of us, eat more or make love more in order to try and cope with. They don't profoundly lead to loss of libido. What you get in PSSD, though, is a kind of domino effect. The first thing that happens, as I say, within half an hour of your first pill is you become genitally numb. And pretty quickly, often within the first time that you make love, your orgasms will be to some extent muted, whether you're male or female. Over time, they get even more mute and maybe absent. And maybe as a consequence of all that, things not functioning, orgasms not being what they used to be, you start losing interest, you start losing libido. But they're all knock-on consequences, it seems to me. And the other big thing then is, if the genital numbing is the key to the whole thing, the question is, where is the problem located? Is it in your brain, or is it peripheral? Is it in the genitals, for instance? My hunch from the start has always been that it's actually a peripheral problem. People, because it happens to them because they're on an antidepressant, think, well, antidepressants go into your brain and they do things in there, which maybe they do, but it seems to me that the key issue here is you've got a peripheral sensory problem, not a brain problem. The people who think their brains have been ruined because of SSRIs probably haven't got a brain problem, and their brains are probably fine. And if we can just clear up the peripheral problem, everything will actually come back to normal. That's my hunch, my hope. Yeah.
Yeah. And a question about the genital numbing. Is the nature of the genital numbing while you're on the drug similar to what it is like when you stop the drug, or does it change in any way, just from your experience?
Well, there's a wide range of things there, which is there's a group of people who, when they go on the drugs, aren't awfully aware that they're genitally numb. As I say, you can run tests on them and show that even the people who aren't particularly aware that they're all that numb are actually more numb than they were before. But you get then a range of things that can happen to people, from some genital numbness to profound genital and groin numbness. I mean, it's not just the genital area, it can be your entire groin, okay? And it can be marked. And I guess the general sense, although I could be wrong on this, is that it's the people who have the more marked problem that are more likely to go on to PSSD. Having said that, what you get reported from loads of people is that, well, I had some genital numbness while I was on the pills, and then I stopped and it got worse. Okay, so that's the usual thing. But my hunch is it's a bit like TD, that you can have the problem while you're on the drug. It's just you don't know you have the problem. You think things are going to be fine once you hold. But there's some people that we can guess, because it's more severe to begin with, probably, that you kind of figure that this is a person, when they stop, it's not going to go away.
So what do you think is going on? Say, like, you have a young chap, they've never had any difficulty maintaining an erection or reaching an orgasm. They go on a medication for a year, and when they come off, they don't have genital anesthesia. In fact, but they're unable to maintain an erection or reach an orgasm. Does this person have a PSSD kind of adjacent problem? Like, especially if, say, they're not depressed or anxious anymore, and they're just like, hey, what happened? What do you think about those people who don't neatly fit, I guess, into that category with prominent genital anesthesia?
Yeah, and it's kind of hard to know, okay? And I mean, my hunch is that there's a wider range of problems than we really know about. You've got the classic PSSD case where you've
Hmm.
got genital numbness, uh, and it will last for months or years. But you've also got a bunch of people who, yes, when they stop treatment, maybe aren't all that gently numb, but things just aren't working. And over a period of months, 3, 6 months, maybe 9 months, things do slowly come back to normal. And whether we should actually call that classic PSSD or not is a bit unclear. Okay. At the moment, the criteria say you have to have the condition lasting for more than 3 months. But, that's just an arbitrary line.
Hmm.
It does seem that there are people who don't have the full clinical picture and do recover over a period of time. But, there's a bunch of other interesting things about this. I don't know if you've ever heard of a condition called CORU. Have you?
Like mad cow disease, or like,
No, no,
yeah,
no, no,
yeah.
no. It's KORO. And I can remember
Hmm.
back when I was training first, there were people talking about unusual and esoteric psychiatric syndromes.
Is this the
KORO.
Malaysian thing?
Yes, exactly.
Yeah.
Yeah.
Okay. Yeah. Yeah.
And it was the kind of thing that as a
Yeah.
trainee in the West, you thought,
Yeah.
oh, that's great. It's over in Malaysia, a long way from here. I don't need to worry about it. And
Yeah.
it's strange. All these people over there must be very strange people. And just for the listeners, it's where a bunch of men say that their penis is shrinking into their body and they're very worried it's going to disappear completely. And they take all sorts of steps to try and make sure that it can't disappear. And, I've sort of thought when I read this first was this is pretty weird, and it's clearly a mental illness. But one of
Hmm.
the interesting things about PSSD that's become a little bit more clear, and it's not just PSSD; it's post-finasteride syndrome also. What you have is a bunch of men. They don't all say it, but there's a bunch of them say, "Look, one of the things that happens is my penis has shrunk." And again, I haven't been paying too much heed to that until recently, when what we've got is loads of people who've got PSSD and PFS and things like that who are doing research on it. Some of them have PhDs themselves, some of them are doctors, some don't have any of these things, but are just highly motivated to try and chase the issues and work out what's going on. And one of them recently was in touch with me and said, look, we know that there's a molecule called Kisspept that's heavily involved, and there's a recent clinical trial of it showing that in people who have hypoactive sexual desire disorder, that this can help. Okay. And one of the interesting things is it's very heavily involved in the ovaries and ovulation, and it's also involved in the adrenal glands. And there's some evidence that when it's missing, when the adrenal links to the genital area aren't working right, that one of the things that happens in rats is your penis shrinks, and when you give the rats kisspeptin, it grows again. And one of the things that happened
What?
in the
What?
clinical trial of this in men who
Yeah.
had hyperactive sexual desire disorder is that they reported, and this was measured, that the penis becomes enlarged again and more like what you would hope it would be. So this left me wondering about all these poor guys in
Yeah.
Malaysia who were complaining about Koro, whether something has happened to them that's affecting their kisspeptin, and maybe their problems weren't as mental as we thought they were. Maybe there's a real physical trigger to these things that people at the time didn't pay any heed to. And that's one of the
Yeah.
things that's still a big issue now, which is some people with PSSD, when they go along to doctors now, are told, frankly, you've got a somatic delusion. There's nothing else wrong with you. You're either depressed, deluded, or whatever, and you should take an antidepressant or you should take an antipsychotic. And this shows lack of insight on the part of doctors, not their patients. So anyway,
Yeah. Puts them, exposes them to more risks, and then also, I could imagine, that there's thousands of people with PSSD sitting in sex therapists' office all across the world at the moment, thinking that something else is going on, wasting their time and efforts there looking for something that they'll never find to explain what's going on.
on
And
that line, on
yeah.
that line. There's a recent video that the International Society for Sexual Medicine put up that had a fairly well-known figure in the United States called Anita Clayton saying that, she didn't think PSSD was a real condition. It's just people who are depressed and they haven't been treated properly. And she's recommending vortioxetine.
Oh God. Yeah.
Uh, and
Yeah.
the problem with that is, vortioxetine essentially is an SSRI that makes people suicidal, just like SSRIs do. And we've had, a lot of reports of people getting PSSD from vortioxetine. So there are a lot of big name doctors out there. When you come along and talk about PSSD, they say, this can't be happening. You are depressed. We just need to treat you with a bigger dose of the drugs than we gave you before.
Yeah, it's awful. I wanted to ask you on another thing. I've chatted with a couple folks who have PSSD, and sometimes, a lot of them describe like cognitive problems. They feel cognitively devastated and that they're in this amotivated, apathetic state. What do you think about that? Do you think there's some unifying pathology that's linking, I guess, the sensory problems in their groin to the cognitive impairment and amotivation that they're having? Or yeah,
Yes, I do. Yeah, no, sure. And that's a key question. And again and again and again, people say to me, at least, you're too genitally focused. Okay. And I'm saying, well, I'm just genitally focused because, you've got an inch or two of skin here that's gone numb. If we can explain why that's gone numb, we'll be able to answer the problem. But clearly, it's not just that. And it's, as I said, there's an emotional numbness there. And I figure that can be explained by saying what the SSRIs do is cause a loss of reactivity. So this is why they're good with OCD. You come down the stairs, the kids have thrown all the shoes all over the place at the end of the stairs. They haven't got them lined up neatly, and you get bothered. But if you're on your SSRI for your OCD, you sail past all these shoes that are not ordered neatly. You're not as reactive to them. Now, that's my hunch is that's a general sensory problem that you're not noticing things the same way and you're not getting as bothered about them. But it's the skin around the body. It's not just the genital area that can be more numb on these drugs. So it's the emotional numbness people talk about. My hunch is it's a sensory problem, and it's what's happening is the sensations we all normally have aren't lighting the brain up the way it would be normally lit up. There's less input to the brain, which leaves your brain feeling that it's kind of dead. It's not processing things the way it should do and things like that. But my hunch is if we can work out what's causing the sensory problem and put it right, people are going to find their brains come back to normal as well. They light up again. That
yeah, I
would be
think
my
that's
hunch.
I think that's really well said. I mean, to me, I would say it also feels like it's like they lose sensory pleasure. The people I talk to, they say, I'll hug my mum and dad or my child, and I won't feel those same feelings that I used to feel. I'll listen to my favorite album from childhood that usually brings back nostalgia and memories and joy, and it's just blunted. And so this whole element of sensory pleasure globally, and at least some of them, is just so muted, and they feel kind of alien. They go, I know who I am, and I'm not myself because I mean, all these things are shut down. It's really disorienting.
Yeah. Yeah. No,
Yeah,
I think that gets it well. And it's an awfully profound problem. You have people feeling, well, if I'm going to be feeling like this for the rest of my life, is there any point going on living? And
yeah,
some of them kill themselves, and some of them figure, let me get in touch with medical assistance in dying program and just end it all because there's no point going on.
on that note, let's talk a little bit about prognosis. I mean, you've read more of these reports than anyone in the world, I'm sure. I mean, I'm sure it's over 1,000 now. How many is it roughly, David? How many reports of PSSD have you read?
Certainly well over 1,000, well over.
Yeah,
It's kind of hard to
yeah,
know just what. And you learn a lot in terms of the way we function. People give you details, give on the reports, they give me details and things like that, which they're a rich trove of materials. It'd be great. I mean, what we need to get is some researchers involved in this. I'm sure there's researchers out there that have the answer to the problem. They just don't know there's a problem they have the answer to. So it's
Yeah.
trying to connect them with the people who have the problem. And I'm sure we're going to find an answer. And somebody who comes up with an answer is going to get a Nobel Prize for it, because this can't be explained in terms of receptor pharmacology and things like that. Having made all those points, one of the other interesting things is there's no doubt that people, even after years, can recover. And there's also no doubt that the damage isn't permanent in the sense of people have brief windows. They may be on some other pill, an antibiotic of some sort that they halt. And for a few days after they halt the other pill, everything can seemingly come back to normal before it goes wrong again. So,
Well, let me ask you that one directly then. How would you describe the prognosis of this condition after you develop it?
yeah, well, the it's very hard to. We don't know because there's a lot of people who recover after a period of years, okay?
Yeah.
And the last thing they ever want to revisit is the idea that they had this problem. They're there thinking, let me just get on with life. They don't want to come back and let people like me know that they're recovered. I might find out by accident. So we don't know
Yep.
how many people actually, or what proportion of people actually recover and just what the windows are. Um, my hunch is that there's probably a fairly significant proportion of people who will recover after 3, 4, 5 years, but it can take
Hmm.
that long. We also know that there's a group of people who 20 years later still have the same problem. So, there's
Hmm.
others that just don't recover, at least not in the short term. The big issue here is how do you hold out hope for the people who have the condition? Giving them, the message, of course this recovers and it might only be a year or two, might keep them alive, but it's not the truth. There's a lot of people that it takes a lot longer than that. And it's very, very hard to know exactly what to say to people, other than there's an increasing number of people who are aware of the problem, an increasing number of people who seem to be doing research on it. There's all the people with the problem who are doing their own research and getting places slowly. So there's hope from that point of view. It's the whole thing, actually, one of the key things to bring home to people, I think, is the whole thing is rather like AIDS in the 1980s, which is you have a bunch of people who don't want to admit they have the problem, like they didn't want to admit they had AIDS, and other people now with PSSD don't want to let the world know that, I've got this awful condition and I can't make love, I can't be, the kind of person that I thought I was and would like to be, and things like that. But you've got an increasing number of people with PSSD, like the group with AIDS, who are beginning to mobilize and come out and say, yes, we have the condition and people need to do something about this because it's an awful condition. But a bit like AIDS, you had two groups of people. You had the people with AIDS who figured we need to work with the system. We need to work with the National Institutes of Health. We need to run clinical trials and things like that. And then you had the group of people who are more activists who said, no, we're going to break into the National Institutes of Health and hold people hostage and say, you've got to research this until we actually find the answer. And it's the same among people with PSSD as well. You've got people who are awfully desperate who hear of a lab that may be doing some work in this area and get in touch with the lab and besiege it almost. And then there's the others who recognize that if we're going to find an answer to this, we've got to be methodical. So, it's hugely difficult, and people are reacting in a sense the way you'd expect. They're not all doing the same thing. Some are more desperate and challenging the system, and others are trying to be more methodical and things like that. So,
Yeah. And David, what do you think is what are the current top theories out there about the level, about where the lesion is or where the pathology is? I've heard small fiber neuropathy being mentioned. I was wondering if you could give us the overview of, what are the leading theories about this?
Joseph, that links in neatly to the question of can we get a test? Because one of the problems is people go to the doctor and say, look, I have this. And he or she says, well, no, you don't. This is all in your mind. And this is where having a test like a small fiber neuropathy biopsy, showing on a biopsy that, look, there's a loss of the small fiber nerve endings. That'd be great. It's very difficult to persuade neurologists to do this kind of thing. And they usually do it around the ankle area. And they usually do it in older people. And when you do it in younger people around the ankle, you find that maybe they've got a low normal range, but, it's still falling inside the normal range. Now, is this abnormal given their age? We don't really know. Okay. The other thing that's coming out is that some of the autoimmune antibodies, when people get tested for antibodies, they've got antibodies to the ACE2 receptor, and they've also got antibodies to muscarinic receptors. And this kind of suggests that there's an autoimmune problem here. One of the other things that we're trying to explore at the moment is what's called corneal confocal microscopy, which is one of the spots in the body, which people don't realize, is the most densely innervated parts of us, is the cornea of the eye, which you've just rubbed there. And interestingly, just about 10 years ago, people began to realize in neuropathy, diabetic neuropathy, are drug-induced neuropathies, okay, that you can spot in the cornea of the eye, that there's a whole bunch of changes to the nerve endings there. And what we're hoping to get done over the next while is to check and see whether people with PSSD, drug-induced neuropathy, if they've got problems that show up on CCM as it's called. But here's the rub. Among the small fibers we've got, there's the alpha ones and alpha delta, and there's C fibers. But within the C fiber group, there's a group called C touch fibers. And, when I touch you, for instance, you can feel my finger on you and you can locate. I mean, if you had your eyes shut and I tried to touch your back, you'd be able to locate just where I've put my finger. Okay. And that's what's called discriminative touch. But there's also a bunch of fibers that mediate more affective touch, so that if it was your partner stroking you, that's the kind of fiber that will pick up that and you feel it's pleasurable. Now, the problem we've got is in the cornea of the eye around the ankle, we're going to have a lot of small fibers, but do we have these C touch fibers? Because if we don't, and if they're the ones that are the problem, then biopsies and things like that aren't going to show us that people with PSSD who unquestionably have a neuropathy, there isn't going to be a test which shows this. So what I don't know at this point in time is whether there's a test that will pick up missing CT fibers. And that's what I'm hoping the cornea of the eye will have, but we're just going to have to wait and see.
And anything in the pipeline for this at the moment, or are you essentially just waiting for, I guess, people to come back with reports who have heard about this and saying, "Hey, I've got access to someone who believes, a neuro-ophthalmologist who believes me. He's going to look at it, and I'm going to send you the results." Are we kind of just waiting for things to trickle in like that?
A little bit of the problem, bit of the problem is that if the average ophthalmologist who they hear from a person who's been on antidepressants, going to think, well, that's all in the mind problem. And they're going to hear about a genital problem. They're going to say, that's nothing to do with your eyes. So they're not going to do the test for you. Okay. What we've had to do is try and locate some research labs and let them know about the problem. And yes, we've got some promising leads, and you don't want just one person to go along, because if you've got a new problem like this, and with corneal confocal microscopy, there can be a loss of nerve fibers, a loss of fiber length, a loss of fiber density, and there can also be what are called dendritic cells there. Okay, so it's going to take one person in a lab interested in the problem, seeing at least 5 people, I think, to see can they spot what's going on here. Just doing the
That,
usual CCM isn't actually going to produce an answer.
what do I tell people if they come to me and they say, you know what, I'm willing to go and do this. I'll get on an aeroplane to contribute to this. I'll fly anywhere. Should I tell them to email you or something like that? Well, how do I get these people to that place?
Okay, well, I think we have a group of volunteers who are going to do it. And I think we have a lab. Okay.
Mm-hmm.
And I think that's going to give us an answer. Is this worth doing? Now, what people can do
Okay.
in the meantime, and this can be anywhere in the world they're in, they can check. I mean, CCM is a thing that lots of labs are beginning to get. Okay. So you need to check in a place near you whether they have a machine. And hopefully, in the next few months, we're going to be able to tell people either there's no point doing CCM because it's not showing anything, or else we'll be able to tell people this is what you want to ask the ophthalmologist or the optometrist to look for. And it's going to be better if we can give them a strong lead. Like, this is what you need to look for.
Okay. I can't wait to hear more.
Yeah.
So the next thing, where do people get Kisspept? I mean, is that just a experimental drug, or is this something that's on the market somewhere?
Yeah, it's a drug that you can. There's a company. We've got a risk post recently, which gives you exactly where you can go to get it. Trouble is, it's an intravenous injection at the moment. It's not intravenous. I think it may be intramuscular, but it's an injection, and it does help hypoactive sexual desire disorder, but it's probably not going to help PSSD. I know some people who've got PFS who have actually got hold of it and tried it out, and it hasn't helped them. So, you know, there's all sorts of things that we're learning as we go along. There's people taking huge risks, trying out things like this, which, which makes sense based on the research that they're doing. These are things that are worthwhile to try so that we know whether they're going to work or not. But for the moment, Kisspept, while it looks hugely interesting, doesn't seem to be the answer to either PFS or PSSD or
Yeah.
related
So I guess it may really depend on the symptoms that you're having, whether something that's like that is going to be useful. And it may just be like almost like using Viagra for PSSD, certainly not treating the underlying condition, but if your main problem is maintaining an erection, that might get you a little further along, even if it doesn't fully treat it. So it's kind of just trying these different symptomatic treatments to see if anything helps, just make it a little bit better while you wait for the recovery.
Sure. Well, this is one of the binds. There's a bunch of people in the field who say, look, there are lots of little things we can do. And they think it's a good idea to tell people, yes, there are little things like trying Viagra and things like that. There's a lot of other people, though, who, when they go along for that kind of treatment, the little things don't really amount to enough.
Mm-hmm.
So it's kind of, it's tricky. It's helpful in terms of keeping hope there and trying to keep people going until we have the real answer. But I don't think the little things as such, the things that you think might work, like Viagra, don't actually seem to work. At least
Mm-hmm.
not as well as we would hope.
Yeah. Well, I think you've anticipated what my next question was going to be. I mean, just from your interaction with the community, what are some of the things that people have said have helped, even if it's not for everyone? If it's not a blanket statement, just maybe something that's popped up in one or two case reports where someone said, this helped me, even if someone else said, it did nothing.
Yeah, I think one of the things that's emerged for me, and it came as a little bit of a surprise, was the idea that the anticholinergic group of drugs seem to have promise. And one of the interesting things here is that for about 10 years or so, there's been evidence that drugs like benztropine and drugs like that can help regenerate small fiber nerves. For people who've got diabetic neuropathy in animals who've got these things, you can show it clearly. And one of the interesting things about all this is that the anticholinergic group of drugs are a group of drugs that people think are useless. They're no good for anything. They only cause problems. But that's probably not the case. And if you think about the kinds of effects they have, they tend to be more euphoriant than the other drugs we have. And it now looks, as I say, that they do help regenerate nerve fiber endings. So that's a group of drugs for people to think about, do a bit of research about. You can get hold of them quite easily and maybe try them out. The only thing is, if the problem is because we've lost small fiber nerve endings and things like that, these things take months to regrow. So you need to be patient and maybe try out a treatment for 3 to 6 months before you conclude that it's not actually working.
Could you tell us anything about these cases? I mean, is this a theoretical thing, or is this something that a couple cases reported, hey, I started some Cogentin, 0.5 BID, and I've noticed an improvement 3 months from now. I'm not really sure what it is. Where did this thing come from?
Well, it kind of came in the first instance from work done at the Scripps Institute, and this was published, 10 years ago or more, where Merck all of a sudden decided to remove Cogentin from the US market on the basis of this report from the Scripps Institute, which showed that Cogentin was causing remyelination of nerves. Okay, and the idea at the time was that people didn't think it was the anticholinergic action that was doing it. They thought at a low dose, this drug must be doing something else that's different. We can find out what it is and bring some new compound on the market, and for which we'll be able to charge vastly more than you can for an old drug like Cogentin. That was the idea, but it turns out it looks like it's actually the anticholinergic effects that are doing it. I've got a few people to try it out, and this is one of the problems we've got, which is you get people who go on these drugs, they get hold of it, they go on the drug, and it looks like it helps, but you don't hear from them again. They don't want to get back in touch with the people that they link to the problem. So I think there's hints that these things can be of benefit, and the animal work looks quite good, and the clinical trials that are going on in diabetic neuropathy look quite good, and the clinical trials going on as well with cancer chemotherapy. The drugs we give to treat cancers can cause peripheral neuropathy, as can alcohol. And so we recognize that drugs can cause a problem like PSSD, for instance, but no one wants to think that one of our favorite drugs, the SSRIs, could be doing something nasty like this. We're happy to blame alcohol on drugs you shouldn't use. And cancer chemotherapy, well, you're taking very toxic drugs to save a life. But actually, the drugs we use, and not just the SSRIs, are probably among the commonest causes of peripheral neuropathy of various sorts.
Yeah. And I mean, I'm just thinking about chemotherapy. That's, PSSD could be a reasonable trade-off for someone with breast cancer or someone with, multiple myeloma or something like that. But for garden variety, mild depression or anxiety, I mean, it is just a nightmare. I mean, the risk completely outweighs the benefit. I think on a more general note, I've landed at a place with the antidepressants where, it's only for the most severely depressed and anxious individuals when all else has failed. I mean, when you look at things through this lens, when they could cause something like PSSD, you're probably aware of this. They're recommended first-line treatments for anxiety and depression in the US. It's right there in the guidelines, which I think is crazy. There's a little more sense, I think, in the UK. I don't know what Canada is like. Do you know if they recommend them first line in Canada, or is it more like the UK?
No. I think the Canadian scene is very like the US scene,
Okay.
and it's one where you get put on pills, and if the pills don't seem to work, we figure you need a higher dose rather than to hold the pill, and we add in more and more. So routinely, more and more, you're seeing people who are on 5 or 10 different psychotropic drugs rather than just one. And they begin with a reasonably mild problem and end up with a basket full of drugs.
Yeah. Well, that's all I have time for today. David, it's been so good to talk to you about this. For anyone that made it this long in the interview, and I'm sure there are some people who are very interested in this because I have a lot of PSSD folks who are now stopping by the channel. In the comments below, I would like you to ask questions because I will get in touch with David again, and I'll ask him if he's kind enough to come back. And so, the more the merrier. Please list them in the comments below, and we'll do this again sometime. So, David, thank you so much for doing this. It's been a pleasure.
Joseph, it's great to talk to you as always. Okay.
Yeah.
Right.
Okay. Well, I'll let you enjoy your weekend. Thanks, David.
Bye.
Bye.
Bye.